real quick. There we go. Okay.
Great. Thanks, Jenny, and welcome everybody. So this evening, Kaylin and I are going to try to explain everything that's happening in Medicaid right now, which I haven't, if I didn't check my email in the next 5 minutes, I'm sure it has changed. But so we hope to explain it in a way that makes sure everybody understands what's happening, but just know that it is rapidly changing and we're trying very hard to keep up with everything. And what you know tonight may not be accurate by 10 a.m. tomorrow morning. So just to get us started, what we're going to really do today is in order to understand everything that's happening with Medicaid in the federal landscape and potentially like what that means for North Carolina and North Carolina Medicaid and our services, we first sort of have to understand some basic Medicaid terms and how it's structured. So we thought it would be helpful to give that kind of basis. So we're not going to try to teach you all of Medicaid. That would take a very long time, but we are going to try to teach you some of the basic terms. So that you can understand some of the words that are going to be thrown around both later when Kaylin explains everything that's happening at the federal level, but also as things move pretty quickly in the next couple of weeks or months, as Medicaid may change and the threats to Medicaid are occurring. So when terms are thrown around like FMAP, which we'll explain in a couple of minutes, you'll know what that means and you'll know sort of the impact, the changes proposed potentially to the FMAP, what that means and how it affects services. So, and then we're going to talk about sort of the current proposals and at the end, and then we'll also have a Q&A. So we'll take a little bit to explain everything that's basics in Medicaid so you get all the terminology, and then we'll really move into what's happening. So if you signed on and are like, why am I learning the basics of Medicaid? That is why. So what is Medicaid? I think a lot of people know it's part of the Social Security Act. It was created in 1965, and it is a voluntary joint federal and state level program, and it provides healthcare coverage for nearly 80 million people in the United States. And what does voluntary mean? It means that when Medicaid was first enacted, not every state signed up. I think it took until the early 80s for New Mexico to even join the Medicaid program. So it is funded jointly by the federal government and states. And the Center for Medicare and Medicaid Services, or CMS, is the federal agency that oversees Medicaid. And that is under the Health and Human Services Department. And then at the state level, there's a common saying in Medicaid that if you know one state Medicaid program, you know exactly one state Medicaid program, and it is very true. States have a lot of discretion in how they administer their programs. So even as there's threats to the Medicaid program, how different states react to that can vary quite a bit depending upon how much leeway there is in any of the federal or national changes. And so one big thing is that states can determine eligibility standards and which optional services that enrollees can use within federal minimum requirements. But I will say that a lot of states choose a lot of optional things to add on to the basic Medicaid program. So like North Carolina does have quite a few optional things, and we'll get into that. And when things are optional, that means states can cut them when they're facing financial challenges or otherwise want to change to cut the program. So why are we so like sort of, oh my God, something's trying to challenge Medicaid and hurt it? Because Medicaid is the largest source of healthcare coverage in the country. It covers about 79 million people, most of whom are kids, so about 47%. It's 1 in 2 children. It funds $4 to $6 billion to school districts, so a lot of school services are covered by Medicaid for Medicaid enrolled children. And that's oftentimes not even like schools don't even maximize as much as they could bill to Medicaid. It does cover over 60% of nursing facility residents. A lot of people think that's Medicare. It's actually mostly Medicaid. And then 1 in 3 individuals with disabilities are covered, as well as 1 in 5 Medicare beneficiaries have both Medicare and Medicaid. It covers 41% of US births. And one of the hot topics that Kaylin will cover later is about work. And that there's this idea that many people on Medicaid are not working, but in fact, 64% of non-elderly adult Medicaid beneficiaries are working, and 29% are not working due to illness or disability, caregiving, or school attendance responsibilities. And we'll talk more about that later. So, like I said, I used this term at the very beginning called FMAP. Um, and I will warn you that if Kaylin and I start talking in acronyms, please sort of raise your hand or otherwise sort of make us aware, because we can have whole conversations just in acronyms because Medicaid is full of them. But so states receive funding based on actual cost of providing services. So if a doctor bills um, a service in a fee-for-service Medicaid system, which is when the doctor bills it and then the state just pays it, the state will then get its federal matching money for that service. Um, and how a state gets that money depends on the state's what's called FMAP. So that's the federal, so FMAP actually means Federal Medical Assistance Percentage. Nobody ever wants to say that, but what it really just means is that it's how much of percentage the federal government pays. So for example, the highest state's FMAP is 76.9% in Mississippi, and the lowest is 50%. It never goes below 50%. So usually it's about, a lot of the southern states without a lot of sort of state revenue and income have higher FMAPs. So in there is an enhanced federal share for certain groups and services. And Kaylin will talk a little bit about that later with Medicaid expansion. And for every $1 spent by a state, the state gets a matching $1 to $3. So this is a lot of federal money coming into a state. And currently, as the Medicaid program exists right now, it's open-ended matching funding. So whatever the state spends, the federal government matches it according to the FMAP calculations. It is the largest source of federal revenue for states. Typically, it's second to state spending on education, so in terms of a state's budget. And one thing to really note is that enrollment is counter-cyclical with the economy, which makes sense because as people maybe lose work or otherwise have economic hardship, they may become eligible for Medicaid because it is a income rule, like based on income eligibility program. And like I said, every Medicaid state plan is different. So one thing to know as we're starting to talk about Medicaid cuts is to know that there are some mandatory services under Medicaid for what's called full scope Medicaid or full coverage Medicaid. There are some mandatory services, but a lot of really critical services are optional. So for example, prescription drugs is an optional service, and like private duty nursing, personal care services, other home and community-based services like our Section 1915C waivers. So in North Carolina, that's innovations, Cap C, Cap DA. They are all optional. Other important ones like rehabilitative services as well are all optional. So those could be cut, and the state maintain its obligations to the Medicaid program. So like I said before, the state can really choose and pick and choose a lot of things in Medicaid, including eligibility. There are over 40 categories of possible Medicaid eligibility. There's not that many mandatory eligibility categories. So for example, very low income children and pregnant people are part of the mandatory populations that are covered by Medicaid, and former foster youth. But states, including North Carolina, often put a much higher income allowance for families and children's. They also, for example, uh, give Medicaid eligibility to certain people receiving home and community-based services. And North Carolina, as Kaylin will talk about later, did expand Medicaid to the adult population, which is up to 130% of FPL. You'll see this acronym in the presentation. It means federal poverty level. It's a standard set every January of what the federal poverty level is. And one thing to note, because this often comes up, is that Medicaid is actually not that available to most immigrant populations, and is really not available at all for undocumented immigrants. So certain like immigrant categories, different are allowed to get Medicaid. I won't go into it. I could fall into that rabbit hole, but I won't. But just be aware that there's often a lot of misinformation about the availability of Medicaid for immigrant populations. So, as we talk about what's at risk for Medicaid, one thing to understand is that before the Affordable Care Act or the ACA, Medicaid was really targeted to certain categories of people. So, for example, aged, blind, and disabled people receiving supplemental security income under the Social Security Act, pregnant persons, foster children and adoptive children, children sort of generally low income children were all sort of the categories of Medicaid eligibility that were available. And you had to be low income, and you also have an assets test. So how much sort of savings and such do you have available to you? And then post ACA,
Can I ask one question real fast? Can you
yeah,
go back to the slide?
mhm. Here or
Um,
one more.
no, this one.
Okay.
When you talk about age blind and disabled, I just wanted to point out that it is receiving SSI, so the whole family has to be income eligible, not like a waiver like CAPC or Innovations where it can be just the child's income.
Right. And the fact that North Carolina allows it to just be child's income and thus be able to be eligible through like the 1915 C waiver, the Cap C waiver, for example, is a state choice that is completely optional. A state could say, we're not going to do that anymore because we need to restrict our program, and we're only going to go back to either only providing it to people with SSI, or they could say we're going to have a lower income level because North Carolina currently has a fairly generous sort of income choices, especially around home and community-based services like CAPC. So just to understand sort of when people talk about repealing the ACA or otherwise sort of taking away Medicaid expansion or doing anything that affects sort of the Medicaid expansion population or Medicaid in general, you should understand that the way the ACA was set up, it was to create sort of a continuum of healthcare coverage options. So there's Medicaid that was supposed to be for at least 0% of federal poverty level to 38%. It's higher in a lot of states than 38. And then there was supposed to be Medicaid expansion, which would cover people up to 138% of federal poverty level. And then the marketplace subsidies were supposed to kick in 100% of federal poverty level or above. When there was a bunch of challenges to the Affordable Care Act and Medicaid expansion became optional, as we all know that North Carolina did not expand. And for a long time, we had this no coverage gap of people who were below 100% of federal poverty level, but didn't fit into any of the Medicaid categories of eligibility. So I'm going to turn it over to Kaylin now to talk about North Carolina Medicaid expansion, and then she's going to get into the nitty-gritty of all of these things. But if there's any really quick questions, I think, about the basics of Medicaid, maybe, I don't know if we want to take any of those now, Jenny, or just keep going.
Sure, if we have any, feel free to drop them in the chat.
Get started, and then people can we'll answer them as we go. Oh, she muted herself. Oh no.
There I am. Hi, we can do this. Everything's going great. Hi, everyone. I'm Kaylin Spransky. I'm a senior policy analyst with Community Catalyst. Just to do a quick introduction and just say thank you for hanging with us on a Thursday night to talk about Medicaid, which I know is a thrilling and enthralling topic of conversation. And you're all going to be big hits at your next party. Um, so I'm also really excited to see names of folks that I know. It's so good to be with y'all again. As Jenny mentioned, I am a North Carolinian. I am from here. I grew up here. I grew up on Medicaid and CHIP myself. I got to come back and do work to help us expand Medicaid. And so just wanting to start off because I know so many of you were part of that for the decade-long effort of trying to get Medicaid expansion here. And so I'm so grateful for all of your work, all of your storytelling, all of the calls you made, everything that you did to help us get that bill passed. And then acknowledge that we implemented in December 2023 over 600,000 people have enrolled since then, which is, first of all, just a huge number. So I want to name, for the purposes of our conversation and kind of the threats to Medicaid, North Carolina has a very large Medicaid population. We have a huge rural portion of our state, as we know. It is really, really important to our state. Not every state has a Medicaid expansion population that is as large as ours. So that's going to be important for us to consider. So as you can see, we got some breakdowns of who is enrolled in expansion. Again, that is our newest avenue to get care and coverage in North Carolina for folks who make, and I have some kind of estimates of what those federal poverty limits are for folks to be able to qualify for Medicaid. They are quite low. I think we can all agree. It's hard to make ends meet on $21,597 as an individual. I would not know how a family of four could do that. It is a lot of burden to take on. So also naming that because we're starting to hear a lot of rhetoric coming around from the news, from people in Congress, folks who are trying to paint folks who are enrolled in Medicaid with a brush that I think is very unfair. I'm going to talk about that a little bit more, but I want to name that we have a huge portion of our state that is getting covered and access to this life-changing care through expansion. I want to flag a few things because we are talking about some of the threats specifically. So I want to talk about what North Carolina has done and how we pay for the state's portion of what it costs to run Medicaid expansion, right? But before I get into that, I do want to name that there is a provision in our bill, House Bill 76 is what got us Medicaid expansion, that it includes a provision that requires us to create a workforce development program for the folks who are enrolled in Medicaid expansion. If the federal government, through the Centers for Medicaid and Medicare Services, which kind of are the overarching umbrella agency that states who have Medicaid, so that's all states right now, kind of have to answer to, right? That's who's giving us the money, and that's also who states are kind of asking for things like waivers and all of that good stuff from. So this previous administration, the Biden administration, was not interested in approving states for any sort of additional eligibility requirement, including a work requirement or even a work training and employment job opportunities program. They wanted to keep Medicaid eligibility just tied to your income level if you are a resident of the state and if you are a citizen or a legal permanent resident, and that's it. We know that the current administration has signaled that they are interested in states that want to potentially attach additional requirements to their eligibility, especially for the Medicaid expansion population. So right now, as it stands, North Carolina is looking at standing up this workforce development program by next year. We don't have it yet. What is currently on the books in our law is that it would be optional for the folks who do qualify for Medicaid expansion. That could change, either because the state chooses to change it or because Congress could compel states to have to do something like a work requirement. And again, I'm going to get into some of those details and proposed policies in just a second, but I wanted to name that. I also wanted to name something that I saw earlier this week that came out of Representative Donnie Lambeth, who is one of the champions for Medicaid expansion in the legislature. His office has been crunching all the numbers, and they keep lifting up that 73% of folks who are enrolled in Medicaid expansion in North Carolina are employed, and that the folks who are not currently employed are exactly the population Elizabeth talked about earlier. They're students, they're people going to school, they're parents of kids that are dependents that need them to stay home and take care of them, or they're caregivers of folks with complex or chronic medical needs or mental health needs, behavioral health needs that require a higher level of care from a caregiver. And so it makes it really hard to have a job. Again, I grew up on Medicaid because that is how my family could get health care. I take personal offense to when people are being painted as lazy or looking for a handout. And I just don't think it's accurate, first of all, but I know that we're going to hear more and more of that rhetoric. And I just want to get ahead of it and say that is not who we know is on Medicaid, right? We know who our neighbors are, our friends are, our families are. And so we're going to have to constantly be part of the chorus of voices that is pushing back and saying, that's not who is enrolled in this program. So I appreciate you letting me take you on that slight sidetrack. Let's get back to business. So like we talked about with our favorite term FMAP, that those dollars that we have some coming from the federal government to help pay for the program and some have to be ponied up by the state. That way everybody is invested in running these programs, right? It's not all falling to the federal government. It's not all falling to the state. 90% of what it costs for Medicaid expansion comes from the federal government. That's part of the ACA, the Affordable Care Act. That's part of the law. That's part of what incentivizes states to expand Medicaid, right? They're getting more dollars to help pay for this population than other folks that are enrolled in Medicaid. Namely because we know that's a huge population. 19 to 64 is a lot of people, and that's a lot of opportunities for folks to have preventative care that can reduce the costs when they don't have access to care, right? You don't have access to care, you can't go to the doctor, you can't contain any chronic health needs, things get worse, you end up having to go to the emergency room more, that costs the state a lot more money. That's why there's so much investment in this Medicaid expansion population. But we still, as a state, have to figure out how to pay 10% of the cost. Definitely better than footing the rest of the bill or even half the bill. But 10% is still a decent amount. What North Carolina and a lot of other states do is they fund most of their kind of 10% that they have to pay through what are called hospital assessments. Hospital assessments are basically fees that hospitals pay the state to support Medicaid expansion. And it's because hospitals get a lot of money when states expand Medicaid. They get a lot of money because they get reimbursed for more people being covered, right? Again, back to if you don't have access to care, you end up in the emergency department more. When that is the only place you can go for care, the hospital has to pay for that out of their pockets. Uncompensated care is what we call that. And it costs a lot more money than it does to help pay for people to be on Medicaid through Medicaid expansion. So this is also a little bit of the hospital acknowledging that they get a huge benefit by more people having health coverage that's going to reimburse the hospital for care, as opposed to more people being uninsured and the hospital having to pay for a lot of uncompensated care. So they're willing to pay for an assessment that helps the state pay for their side, that 10% of the cost for Medicaid expansion. I know it's a lot. This is important because it's something that is being discussed in Congress. So we wanted to name that. So you could kind of see in the whole ecosystem of all of the proposed potential cuts and policies, bad policies that would hurt folks on Medicaid. Hospital assessments is a little wonky, so wanted to clarify that. The other kind of wonky one is, again, around this 90% federal match, the 10% that states have. We call it the 90-10 trigger. 9 other states have this, including North Carolina. But what it is it's another provision that was written into our law that said if the federal government ever decided to reduce their federal match dollars from 90% for Medicaid expansion to anything lower than 90%, the state will end Medicaid expansion. Our law says as expeditiously as possible, which is not great. So some other states that have 90-10 triggers have a longer off ramp for ending their Medicaid expansion if, again, the federal match drops below that 90%. Some states, North Carolina included, are trying to do it as fast as possible. Arkansas's is by the end of the month that the 90% federal match drops below 90%. So we are really concerned for obvious reasons about the potential that Congress could tinker around with that. So let's go to the next slide and get into what's on the table. I'm going to talk through some of these proposed policies, and then I'm going to talk through kind of a state of play of where we are today in this hour. To Elizabeth's point earlier, there's a good chance I could wake up tomorrow and a bunch of things have happened because Congress is just moving at a really rapid pace. I think we can all acknowledge that since the inauguration, we pretty much wake up every day to a new executive order or something else that's happening in Congress. So things are moving very, very quickly. So I want to name that. But as you may have heard, Congress is currently working on a budget that is centered around some massive tax cuts for high-income earners. Like millionaires and billionaires are going to be the folks that benefit from these. The estimated target goal for these tax cuts, what they want to be able to save, save being the high income earners that are going to benefit from these tax cuts, is $4.5 trillion. $4.5 trillion is a whole lot of money. And Congress can't just add $4.5 trillion to the deficit. They can't just say, we are going to make an additional $4.5 trillion debt, and it's somebody else's job to figure out how to pay for that. Instead, Congress has to figure out where to find $4.5 trillion in existing programs, agencies, and costs and spending that exist currently in the federal government. So, some of what we have on the slide right now are some of the proposed policies that Congress is looking at to get to those cuts so that they can do $4.5 trillion worth of tax cuts for high-income earners. I'm going to walk through these because they don't tell you anything about what they are in their names. So we're going to start with a per capita cap. You might hear it a per enrollee cap. Some news outlets are calling it that. Some people are calling it per person caps. But essentially, it is where the state is going to receive a set amount of dollars for each individual that is enrolled in Medicaid. So the way I think about it is, let's say we're all on Medicaid. Every single one of us the state is going to get $10 for. My care might cost more than $10. Elizabeth's care might only cost $5. But the state has to figure out how to reconcile those differences, and they're not going to be able to just make up the difference from state revenue, right? It's a lot of money. But that is the proposal. States will get a certain amount of dollars per enrollee, and they will be told you can do whatever you want with that to cover that person's needs. The other similar type of proposal is called a block grant. A block grant is similar in that instead of it being per enrollee, the state is going to receive a chunk of money from the federal government, and they're going to say, here is your Medicaid money. You can run your Medicaid program however you want, but this is the amount of money that we are going to give you from the federal government. Nothing more. I've talked about this before when we were here for repeal and replace in 2017. Like this. It is akin to it's your birthday, and somebody comes up to you and says, "Happy birthday. I want to treat you. I want to give you money so you can go have dinner wherever you want. You can bring whoever you want. You can do whatever you want. It's all on me. Here's $5." Well, you can't go wherever you want. You can't even maybe eat a meal at McDonald's for $5 by yourself. What a sad birthday. Because in reality, while they're saying you have all this flexibility to make whatever choices you want, they've only given you $5 to do that. So it's not real flexibility. Both of these proposals, the block grant and the per capita cap, also don't do what Medicaid currently does, which is grow as needed to address a couple of things. Things like inflation, things like population increases, but also really importantly, things like emergencies, things like public health emergencies, or say things like hurricanes coming through the western part of our state. My parents live in Lake Lure. They are okay. But they had to experience not only the devastation of their house being wiped out, but all sorts of health needs that came up because they couldn't get potable water. They didn't have access to the care that they needed for weeks because of this. So all of those costs, all of those emergency things would not grow with the Medicaid program like it is currently set up to right now under a block grant or a per capita cap. The federal government would say, you got the money you got, and it is up to you, state, to make those choices of how you're going to run things. That also means a couple of things. The state could run out of money for Medicaid. You get the money you get. That's going to shift a lot of costs to the state. We know that states can't suddenly make money appear, right? We can't just suddenly make revenue. So the state is then going to have to make some really impossible choices. They're going to have to do things like decide if they're going to cut eligibility for people, if they're going to limit the types of services. Remember those optional services that states have? Prescription drugs is an optional service. If states can't pay for their full population that they're covering for Medicaid, they might have to take away covering prescription drugs or the costly prescription drugs so that they can save money to try to cover more people. Remember, they're going to still have to cover those mandatory groups too, right? Those folks, those folks that are considered mandatory are still going to be mandatory. So they're going to have to cover them, and they're going to have to figure out how to cover these services. So they might say, we can't do all the prescription drugs. Dental, can't cover it. Can't cover rehab services. You're not going to be able to get private duty nursing because we don't have enough money, because the federal government stopped giving us money that was there to meet the needs of the people that were enrolled in Medicaid. The other thing, if we can go back to the other slide, thanks. The other thing is our old friend, the FMAP, the federal match. Congress is looking at a bunch of different ways to play around with this. Like Elizabeth said earlier, all populations that are covered under Medicaid come with some level of the federal government giving the state money to help cover them, right? For Medicaid expansion, like we talked about, it's 90% of the costs. That's a lot of money that the federal government is giving us. I would argue it's really important to cover 600,000 North Carolinians and then some. But they might reduce the federal match that they provide states. They might do it specifically for Medicaid expansion population, which would then also trigger our 90-10 trigger and end the program. They might do across the board cuts of their federal match dollars. They might say every population covered under Medicaid is getting less money from the federal government. State, you have to figure out how to deal with that on your own. That also is going to significantly decrease the money that states have in their state economies. When states get money from the federal government for Medicaid, it's not like the state says, these dollars are for Medicaid expansion, folks. These dollars are for kids. These dollars are for people with disabilities. They pool all of the federal dollars because that's the only way that they can meet the varied needs of everyone, right? When we talked about per capita caps, I said my healthcare needs were going to cost $10. Elizabeth's were going to cost $5. The only way states can do that kind of balancing in math is if they pull all of the federal funds together and all of the state match funds together, and they say, okay, we have enough to meet people's individual needs because they're so varied. That also means that a huge portion of our state's budget is built on Medicaid, specifically federal Medicaid dollars. In 2024, a federal state or a federal expenditure report, they come out every year, shared that Medicaid makes up 56% of all federal funds that go into states. So that's over half of the revenue that comes into the state from the federal government is explicitly from Medicaid. If any of that is reduced, that's going to have huge ripple effects over state economies. So again, states are going to have to figure out how to fill those holes and fill those gaps in their budget. And that's going to come on the back of the folks who are enrolled in Medicaid. So I know that's a lot, but wait, there's more. I'm going to take a sip. All right. Something that's not on the slide that we alluded to earlier were these work requirements. We talked about how North Carolina has one written into our law for Medicaid expansion. Congress is talking about looking at other ways to generate savings to pay for those $4.5 trillion that they need to do tax cuts. In addition to the policies, the proposed policies that are on the screen right now. One of them is a mandatory work requirement. I want to explain how that becomes a savings for the federal government. It creates savings because there is one thing that research has demonstrated time and time again for any program that has a work requirement attached to it, including the states that have done work requirements for Medicaid in the past, SNAP, food stamps that have work requirements currently, cash assistance or TANF that also have work requirements currently. And this is what all of the research shows us. work requirements do not increase employment. They do not increase individuals' income. If they do, it's very rare or erratic. Some people could maybe see a little bit of an increase, some people might not. The one thing that work requirements consistently do across all of the programs they're a part of is they disenroll people from them. That is the only data point that they show. So, why Congress wants to make work requirements mandatory for Medicaid, especially Medicaid expansion, folks who are enrolled in Medicaid expansion, is because they know that there will be fewer people that are able to stay on the program because work requirements kick people off. Not because they're not eligible, but because they are not either able to keep up with the monthly reporting. It's a lot of red tape, it's a lot of bureaucracy. Or if states are looking at using back-end data matching systems to prove that somebody is working. We know how often state data systems are wrong. Data is only as good as how it's put in, right? Somebody misspells somebody's name. You've changed your name. You got married. Congratulations. But the back-end system doesn't know that. You might work different hours. You might not have a normal 9 to 5. You might do seasonal work. You might do agricultural work that has seasons to it. Those things aren't accounted for in back-end data systems. And then requiring somebody to report that every month or every year requires people to keep up on paperwork, specific paperwork that the state wants, all of those red tape, all of those hoops to jump through is why people get disenrolled. And so Congress is planning on people being disenrolled as a way to save money for tax cuts. And I just want to make that clear. So that is also something that is being discussed, just again, to reiterate, more specifically for the Medicaid expansion population. And again, we know Medicaid expansion is so critical beyond what they're calling able-bodied adults. It covers youth, right? It starts at age 19. I consider that a youth. Young people, individuals with complex medical needs, people with high needs, behavioral health needs, people that aren't going to qualify for that very narrow disability Medicaid because of those narrow SSI limits. Many of them, as we know, are covered under Medicaid expansion. And so these work requirements could impact them. All of these cuts could impact them. They're coming for Medicaid expansion. They're coming for Medicaid in total. So let's talk about what is actually happening right now. And I'm almost done, I promise. I know I'm yapping a lot, but hang in, and then we'll turn it over to y'all to ask us a bunch of questions. So we're in a time called budget resolution season, which sounds, I don't know if it sounds fun. It sounds better than it is. But budget resolution is essentially when Congress says, okay, many different Congress committees, also Congress committees oversee federal agencies. They do things like determine what policies and laws are going to be passed about them before it goes to the floor for a full vote. They help set appropriation and budget limits, which is what budget resolution is a part of. So right now, all of the committees in Congress are being tasked with coming up with target numbers that they are going to set as goals that they then have to meet to create a budget. So that $4.5 trillion that Congress wants to pass for tax cuts has to come from cutting programs in other places. So the committee that I'm going to talk about, I'm going to throw it in the chat, just so y'all can see what is covered under House ENC or Energy and Commerce. There's a Senate Energy and Commerce we'll talk about in a second. But as you can see, they oversee health insurance like Medicaid and Medicare. The FDA is under this. The CDC is under this. House ENC has got a lot of stuff that is under their purview. Earlier this week, this committee posted their draft budget resolution. That again is going to set that target amount that they're trying to cut so they can get up to $4.5 trillion for tax cuts. That draft resolution came with a directive that was sent to the House Energy and Commerce Committee that they needed to cut at least, so they can cut more, but at a minimum, $880 billion. When you look at what the House ENC committee oversees, we can assume that $880 billion, which is a ton of money, will largely come from healthcare, if not exclusively from Medicaid. We talked about how much Medicaid pushes into states every year. 50%, 56% of states' revenue that comes from the federal government is only from Medicaid. So Medicaid, of all the pots of money that are available to cut under the House Energy and Commerce Committee, Medicaid has one of the biggest ones. So if they're going to take $880 billion from somewhere, a good chunk of it, we can estimate, is coming from Medicaid. So we also have, so we don't know what those specific policies are yet. Again, budget resolution is just setting target dollar amounts. Committees will be required to report those proposed policies. Right now, they're saying March 27th. That could change because there are a lot of things happening in Congress right now. The House and the Senate are currently disagreeing on how they want to do these tax cuts. The Senate wants to do it through 2 different bills. The House wants to do it in 1 bill. So we don't know exactly how accurate the timelines that they're proposing right now are. We're going to find out together. Again, we don't know specific policies that they're looking at yet. We will see more of those in March. But just hearing the sheer magnitude of what they've been directed to cut, $880 billion, we can assume that any cuts that include Medicaid are going to have to be big enough that they are structural changes to the program. Those are the things like per capita caps and block grants, changes to the federal match, work requirements like we just talked about, removing provider assessments or limiting what states can do with that so that states can't use that to help pay for their portion of Medicaid expansion or other state matches. It doesn't matter at the end of the day what the avenue of those cuts are, because what matters from my vantage point as an advocate, the folks who are enrolled in Medicaid are going to bear the brunt of whatever these cuts are. To the question, thank you for that, Elaine, who directed the 880 billion cuts. That came from Congress. So the President Trump has said, I want to do my full tax package. They set with congressional leadership that $4.5 trillion target number. And so congressional leadership is now who is saying, okay, your target is going to be 880 billion in this committee. This committee is going to have a different target, et cetera. So that's kind of how it's working. But let me know if you have follow-ups or that wasn't clear. But like I was saying, at the end of the day, any cuts to Medicaid are going to be felt by the folks who are enrolled in Medicaid, even if the proposed policies to make those cuts aren't directly saying we're going to cut this eligibility category, this group of people that can get Medicaid, or we're going to remove these services from being able to be covered by Medicaid. Because we know that all connected, right? All of the dollars translate to people getting access to care and having access to services. So on the Senate side, they're taking a different approach, like I said. They want to do a two-bill process. So they want to start with a smaller bill first that is only going to address the border part of what they want to do in Congress and defense spending. And then do a second bill that is only about the tax cuts. The House disagrees. We don't know what we're going to end up with, to be completely honest. The Senate side of things, so the Senate committees are also working on their first budget resolution, but they're working on it for their first smaller bill, the one that's focused on the border and defense spending, that passed out of committee on party lines, just so you know. The markup for that first smaller package. So again, remember, they're planning on doing a second bill that's just the tax cuts in the Senate. But this first smaller package, even though it is not focused on the big tax cuts, they have still directed committees, Senate leadership, to cut at least $1 billion from the Senate Energy and Commerce Committee, that also is the Senate side that oversees Medicaid and everything. One really important thing that came out of the Senate about this minimum $1 billion cut. They said that there are no restrictions on what could be included, and they could go far over 1 billion if they wanted to. So they are not saying you can't touch Medicaid, you can't touch Medicare, you can't touch some of these programs. They're saying you have no restrictions. It's got to be $1 billion of cuts at the very least. And if you do more, cool. We are going to get the Senate proposal for what their proposed policies are for their first bill, that first one on defense and border spending, by March 7th, theoretically. Again, all of these things are changing constantly. So to the question about, does this affect Medicare as well? President Trump did a lot of campaigning saying that he would not touch Medicare or Social Security. But there is nothing, and this is why I raised that on the Senate side, there were no restrictions for what could be cut. While that is something that President Trump said during the campaign, the Senate, at the very least, is demonstrating that they are not putting restrictions. So even though President Trump said, we're not going to cut Social Security or Medicare, the Senate is saying, you're going to make a minimum of $1 billion of cuts for this first bill, and we are not going to restrict you from where those cuts are coming from. So it could technically include Medicare. They're signaling that nothing is off the table for these cuts. And so we don't know, again, yet what those are going to look like. We're thinking early March is when we're going to find out what those proposed policies are. But this all equates to the time to take action and start calling members of Congress in both the House and Senate is right now. So we can go to the next slide and we will send these around. We have a lot of resources for you. I'm going to add some additional ones in the chat. Again, we'll follow up with Jenny to make sure all of these come your way. We just released this on work requirements from Community Catalyst. But we have NHELP has a beautiful I think I got the right one. Okay. A beautiful landing page for all of their Medicaid defense materials, resources. There's analysis on how things will harm populations, how different cuts are going to impact different populations, how to protect Medicaid funding for their states. Our landing page has, I've got a couple, but our landing page that I have up here is going to include a lot of resources for you to adapt. They're all unbranded, so they don't have Community Catalyst or anybody else's name on them. Free, open reign, but we've got fact sheets you can use. We have a lot of resources in there, so you can plug in different data as you want. Template op-eds and letters to the editors, template email scripts and call scripts so that you don't have to figure out how you want to say don't cut Medicaid, and you can adapt all of that. So I will put those link again in the chat now now that I am done talking, and I know we have a couple of questions, but I will kick it over to Jenny and Elizabeth for just a second while I pull these links.
And thanks, Kaylin. I wanted to quickly add that one of the other things you'll hear as a talking point about work requirements is that work is tied to health and work improves health, which is not exactly sort of tied the way that some people may want it to be. So for example, I think there's a really good example from the last time around when certain states asked to implement work requirements, and InHelp, the National Health Law Program where I work, InHelp really led the charge on fighting those work requirements in the courts, and which is why we have a lot of resources about work requirements now. But one of the really sort of telling stories that came out of Arkansas, which was the only state to really implement the work requirements, and there was a ton of harm in a very short period of time, was the story of Adrian McGonigal, who is Googleable. There's a really great PBS story about him. He sadly passed away recently, but he was working, had his first job in a really long time that he thought was really stable. It was not a fast food job. He was working in a factory and had regular hours. And he had various health conditions, and Medicaid expansion had really actually allowed him to go to work and have his healthcare needs taken care of in Arkansas. And then when he was unable to, he was meeting the work requirements, but was not actually able to meet the administrative pieces of it, despite his best efforts. He actually ended up losing his job because he lost Medicaid, because he lost access to prescriptions that he needed to be successful and be healthy. And so I just wanted to flag that there's all these stories that somehow there's studies that show that working is related to health, but actually a lot of those are much more about whether or not you are able to be out of poverty and and able to address other needs. And so I just really wanted to flag that you'll hear a lot of different reasons why work requirements are great, but what I really wanted to emphasize that, as Kaylin said, and I think that the experiences of people who have been through work requirements either through SNAP or the few states that even sort of started to do work requirements, is that it really is just an administrative burden as a way to kick people who may actually be eligible off of the program to save money that way. And I see we have some questions, so we'll
Yeah,
start with
actually, it
those.
looks like Kaylin's answering some of the ones that are in the chat. And John, I do see that your hand is raised, but figure the benefit of hosting this is I get to ask my questions, right? And some things that I think will be, especially the first few, like foundational things, not specific to what's potentially to come, but just to really better understand Medicaid. So first of all, are either of you aware of what the FMAP is for waivers specifically, like 1915C waivers?
So the waivers are funded at the North Carolina's regular FMAP, which actually I just looked it up, and now it's somewhere around 67% was North Carolina's current FMAP. And so
Yeah,
waivers
I
are funded
think
at the
I
same
remember
level.
hearing that. Yeah, for every $1, it's $2, and then that makes the whole. So that makes sense. So it doesn't matter what the program is, the FMAP is what rules the rate. Is
Yeah,
that
the only
correct?
thing that matters, the only thing that gets enhanced rates currently in terms of the enhanced FMAP are it's a few discrete things, but the Medicaid expansion population has enhanced FMAP. I mean, has the 90% FMAP. It's not enhanced, and like family planning has a little bit higher FMAP, and so there's a few other little things, but almost everything is funded at the regular 67% that North Carolina has. And I did want to answer a quick question that's in the chat about sort of how do you protect funding for waiver populations, including people with intellectual and developmental disabilities. I will tell you, as a Medicaid advocate who's been doing this for a while now, every time a state has to start looking at how to cut its Medicaid budget, one of the first places they look is HCBS, so home and community-based services, including waiver populations. Because when they look at the grand scheme of things, that is a very expensive part of the budget because, comparatively, people with disabilities and older adults take up a much an outsized portion of the Medicaid dollars, compared to how much other Medicaid populations sort of cost the state. And so almost every single time, one of the first places they look is waiver programs and like personal care, personal care and state plan, private duty nursing, because it's very expensive. And so the best way to protect access to those really critical home and community-based services is to protect access to Medicaid overall. One of the main things they want to do is pit populations against one another. And like that's particularly dangerous. And I would say like don't fall into that trap because at the end of the day, a cut is a cut is a cut. And one of the first things that is always targeted are these really intensive home and community-based services because they are expensive.
Yeah, and that's a great segue into another thing that I was just thinking of as you were going through this. I feel like our state has done a really good job over the last few years of different populations coming together to advocate for improvement of Medicaid for everyone. And I feel like this is just it has the risk of pitting communities of Medicaid recipients against each other. And that's just really concerning after all the work that we've done to come together. Any thoughts on that? Other than yes.
I mean, other than, yeah, so um, yes. And I think that pitting populations against one another is a way to divide the power of the populations, in terms of fighting Medicaid cuts in general. Like I want to re-emphasize what Kaylin's point was very early on, is that these cuts and targets to Medicaid are happening to give tax cuts to the very wealthy people in this country at the expense of people who need healthcare and rely on healthcare from Medicaid. So just sort of the more you get divided, the more they're winning in terms of being able to sort of piece out the program and make cuts in general.
Mhm. One question I had about block grants, because I know that there are currently block grants that fund different parts within DHHS. I don't think Medicaid specifically. So are those at risk of being cut, number one, if that's within DHHS? And number two, does none of that block grants, I think, like Kaylin said, is going to be just a set amount of money, like say North Carolina get $500 billion and figure it out. Is that correct?
Yeah, I mean, it's going to be a little more complex than that, but basically what it's going to equate to is the federal government is trying to create a situation where they can say, we know this is exactly how much we're going to spend on Medicaid so that we can guarantee that we will be able to put this chunk of money as savings towards that $4.5 trillion for tax cuts. And the only way they can do that is by limiting what they're going to give to states and being very strict about it. Because they can't be like, we're going to give 500,000-ish and we'll make up the difference somewhere else. The whole purpose of these tax cuts is they're trying to create guaranteed savings so that they can take those cuts, those things that they're called savings, and put them towards the tax cuts that they're wanting to achieve. And they just aren't going to move beyond that.
The other thing I wanted to add, because I don't think we dug into it, but I think it's really important to understand when you're talking about block grants and per capita caps, any of these sort of theories, is that most of them are tying the sort of expenditure to like how much the state will get. It's being tied to sort of, sorry, my dog. It's being tied to an evaluation of what the state has spent or the federal government has spent sort of the past couple of years, and then it's tying it to a sort of consumer price index or other type of index. And what actually happens is that healthcare costs do not rise at the same rate as general like consumer price indexes do. And so over time, like while the sort of penalty or hit may not be great currently because it's based on really recent information, when you tie it to those type of price indices, over time it just starts to diverge. So you really get this sort of, there's a big difference between what the state is being allotted in terms of a block grant or a per capita cap versus what the actual costs and need are, because healthcare and the general sort of consumer price index are not, they don't grow at the same rate. So you're going to end up with a giant gap. So the harm is going to increase over time for most of these plans. And we have a paper about that on our landing page that I shared.
John, you had your hand raised earlier. I'm sorry. If you want to come, I can find you and take you off mute so you can ask your question. There you are.
Hi, I actually put it in chat. Hey, John D'Angelo, I'm the chair of DD Council here in North Carolina. One thing that I think would be super helpful, and I don't know if anyone's running these numbers yet or if it's too early, but if we could get annualized estimates for what this will do to the state budget, I think that would be incredibly helpful. That way we know, hey, this is a 5%, 10% cut to the Medicaid budget this year. I think that would be incredibly helpful.
Yeah,
And I don't know if we're gonna get that.
one of the things that we didn't cover is how much money Medicaid expansion brings into North Carolina every single year. Not just in terms of revenue, like not in terms of like how much federal money they get, but the way in which Medicaid stimulates the North Carolina economy and creates revenue. So for example, like state tax revenues were estimated to increase by like 200 million, and county tax revenues increased by 43 million, in addition to the 1.67 billion that North Carolina got for expansion. Like that's a lot of money and a huge impact, as John said, on the state budget. So this is, but when you see the legislature or even the Congress sort of play with this money, they are just looking at like what they cut. They don't really look at the long-term fiscal impact frequently. And I saw a question about sort of the impact of cutting home and community-based services and, the fact that people may go to institutions. The sort of the distance between those things can be hard to create a fiscal analysis oftentimes, but it's certainly a point to be made, right? Because this is not something that doesn't have a longer term fiscal impact, nor does it has a ton of ripple effects, right? Because you may cut services, but then people end up in other places, whether it's institutions or people may end up in jail or because they get arrested for various things, like, or other ways in which it costs the North Carolina economy and the budget is much broader than sort of just looking at service cuts. But yeah, I think the huge impact of how much Medicaid really stimulates the economy cannot be ignored and is an excellent talking point.
And we're going to see estimates as things come clearer. I see in the chat there's a question about when we're going to find out what the proposed cuts, what all the proposed policies are going to be. Right now, we're thinking March, but again, that could change. And I wish I could give you a more concrete answer, but I'm not in charge of Congress, though I feel
Yeah.
like I'd be really good at that.
I think we're hearing what, like anywhere from March to May, right?
Yeah.
Like,
And some, if the Senate gets their way and does two bills, then the second bill that they want to do that focuses on the tax cuts, where the majority of cuts that threaten Medicaid would come from, could be in October. We're talking about a long haul fight, and it's going to mean that we're going to need to keep calling our representatives, calling our senators, calling Congress to say you cannot cut Medicaid. You just can't. We're not trying to pit populations, to Elizabeth's earlier point, against each other. And any cuts are going to impact everyone who's on Medicaid, whether or not it is through them completely losing Medicaid because the state is deciding to cut eligibility, or it's doing that 90-10 trigger and Medicaid expansion is going away, or the state is getting less money and so they can't provide all of the services that they currently provide to folks. I answered a question earlier in the chat, but want to say it out loud. Depending on what Congress chooses to cut from federal spending in Medicaid, which means they're cutting those dollars again that they're going to send to states, there's very little that the state can do to protect against that. The state can't suddenly fill billions of dollars of a gap in their budget because the federal government has decided to make massive cuts to Medicaid. So the state legislature's hands are going to be tied at a certain point, and that's when the state is going to have to make those impossible decisions of, are we cutting people's eligibility? Are we cutting services? Do we have to do both? Do we have to end entire programs? Because they simply cannot pay for all of this without the federal government paying what they currently pay.
I really
Kaylin, do you
emphasize
think
that like really quickly, that it doesn't, like, I think I see questions about like the North Carolina House and Senate and what they're going to do. Once the federal government makes these cuts, there's very little wiggle room they're going to have. So the time is to the federal government, right? Like the time is to Congress. And to the extent that the state legislature is going to be screaming at Congress to say, like, we cannot operate without this money, that is somewhat helpful, but like it's got to be stopped at the federal government. And I will say that what we know from other programs, that once the federal government block grants it or otherwise puts in like work requirements or other things like that, they do not recover. Right? Like they are permanently changed, they are permanently decreased, and it's permanently far less sort of opportunity and access to services for people that they really desperately need. Sorry, Jenny, I interrupted you.
actually, I think you answered what I was thinking, so you're good. I know y'all are probably reading through questions. If
sorry.
you want to raise your hand as well, I'm happy to call on you and allow you to unmute.
Kaylin, did you want to answer the question about who to reach out to out loud rather than just in the chat?
Yeah.
Like
Sorry.
should people be reaching out to members of the Energy and Commerce
Yeah.
Committee or representatives of North Carolina representatives of Congress? Like where do people direct their energy?
So right now, I would focus on what we call our federal delegation. Call your federal representatives in Congress and your senators. It's important. I mean, there are folks, we can get you the target list. Tom Tillis, I'm not gonna lie, is one of the most powerful people right now in all of this. So I would certainly give Mr. Tillis a call. You can join me. I call him every morning. I'm not lying. um, his poor staffer that has to listen to my messages every morning. But I'm serious. I do. I call every single morning. Those are the folks that I would prioritize. It is so important for them to hear from their constituency, from the folks that are in their district, because they understand that they are beholden to you. You are their voting bloc. You are how they keep their job. Same with our senators. They are statewide. It is important for them to hear from us. I can tell you that I am hearing from a lot of senators' offices and representatives in the House that they are just not getting enough calls on Medicaid. I talk to staffers pretty regularly, and they all report that lately they're hearing a little bit more, but they're just not getting a ton of people calling about Medicaid. And so when they don't get those calls, they use that as nobody cares. So maybe we should cut Medicaid because we're not hearing that people are bothered by this. We're not hearing that this is an issue or a concern for the people that voted me into office. And so I might not care as much. I also want to name that we have a lot of people who are in Congress, especially in the House, for the first time. We call them freshmen. They haven't done this before. They don't know about Medicaid. They don't know about these programs. You would be amazed at what our representatives and Congress people don't know. But that's part of why we need to drive these calls. We need to help them understand that these are essential programs, that this is how we have healthcare. This is how our families can make it. This is how my kid gets what they need. And I don't you cannot vote to take that away because I voted for you. I'm the person who got you into this job. I do think it's important to also connect with your state level reps and senators because they're really good messengers to Congress. Those offices talk all the time. So if you had to prioritize making 2 calls, I would start with your House representative in Congress and your senator or senators. 3 calls. We got 2 of them. And then if you really are just on call kick and want to keep going, then you can talk to the folks at the state level that are your representatives and senators and tell them, I want you to call Senator Tillis's office. I want you to call my representative and tell them that I am telling you Medicaid is important and you can't make cuts to it, especially not cuts so that billionaires and millionaires can get tax cuts and we can't get health care as a result. Because that is the reality of this. That's what this equates to.
I'd also add to that, there's a real misunderstanding, especially as Kayla mentioned in the freshman sort of congressional delegation, but even in longer term congressional delegates, they do not know who is on Medicaid. They frequently sort of listen to the rhetoric that Medicaid is people who are not working. Medicaid is these sort of childless adults in Medicaid expansion who aren't doing anything. We all know that that's not who benefits from Medicaid, and that's not who really needs it. And so I just wanted to flag that the more if you have stories about how your family benefits from Medicaid, that can be really critically important because it dispels a lot of the rhetoric and myths about what Medicaid does and who's using it and how it helps.
I noticed some folks were flagging that Senator Tillis's voicemail gets full fast. I will say, when you call first thing in the morning, I've never run into a full voicemail. So just throwing that pro tip out there. But there are times of the day. And if you get nervous, because it's nerve-wracking to call folks and have somebody answer and have to try to make your case in very short time. And I fumble over words. As you know, I'm a yapper anyway. We've all learned that tonight. So you can call it off hours because they do have voicemails, and you can leave a voicemail if that makes it easier, if that helps with any concerns about calls. You can
They're
send
also not expecting perfection. They just need to know, they just tally who called about Medicaid today.
literally, if this helps, it is a 20-something-year-old staffer whose job is to say another call about Medicaid, another call about this issue, and that's what they're doing. That you can also send emails. I will be honest, they don't pay as much attention to emails because there are so many auto-generated emails. And like, if there's a big push for an action alert, that's like, if you've ever seen those on Facebook or Instagram or whatever, that's just like, you plug in your name and it sends the message for you. They get a lot of those, so they just don't pay as much attention to them. Calls, they pay attention to, and the threshold of calls that they'll pay attention to is shockingly low. I was once told by Senator Warren's office that if she receives 15, that's it, 15 calls on an issue, it becomes a priority for her. Because that's how few calls they receive. It takes 15 to make somebody pay attention to an issue. So we can do better than that. But I think that's just to, again, demonstrate they're not looking for perfection. And these calls really do matter. They really do care. They don't get calls very often. So this is really important.
And I will say that we beat back threats to Medicaid before under the previous Trump administration. I think we can do it again. It took a lot of stories, it took a lot of calls, but it's not impossible. So, and I think we're coming up on time. Jenny, did you have like any last questions or closing words?
I'm sure there's probably some that we missed in the chat. It's been hard to keep up with those. Does anyone else have any last questions?
I am putting the congressional switchboard number in the chat. 202-224-3121. But yes, what will happen when you call is you'll put in your zip code and it will automatically connect you. And when you're done with your call, you can either call back or you can go back to the switchboard and it will connect you to your senators and the rest of your delegation. So they do it all for you. You don't have to look up individual office numbers. House is going to be in recess next week, which means they won't be in DC. They'll be at their home districts. So you could call their district offices. You can look up their websites. They have all of their district office information and numbers. You could even go down there if you wanted to, if you're feeling real good. But it's a good time to connect them while they're at home, connect with them while they're at home, because they will be in their district offices during the recess. So just another tidbit.
Well, hopefully we helped demystify some of what's happening with all the Medicaid discussions now and give people clear sort of things they can do. And just recognize that, just remember, don't let anybody divide populations. Don't let people pit you against one another. And that any cut to Medicaid is a harmful cut to Medicaid. And it'll all trickle down to harm some of the most at risk and sort of people who cannot take sort of less services or less cuts or less services or less sort of benefits.
And just thank y'all for
Thank you.
hanging out with us on a Thursday evening, talking about Medicaid. And I really love seeing that people are going to call tomorrow morning. I'll be with you. No, but really, more information is going to come out. You can always follow NHelp or Community Catalyst. We are often sharing information together. But as we learn things, we will pass them along. And we're just, again, really grateful for all of the things that you're doing and for the opportunity to talk to y'all. And so I hope everyone has a good night and dreams of good Medicaid.
Well,
Thanks y'all
thank
so
you
much for
guys.
joining us.
Yeah, thank you, Elizabeth and Kaylin, for sharing such important information and timely information. We've been talking about doing this since I think November, and we couldn't have picked a more perfect time for this to come out. Make sure that everybody's understanding what's going on, opening our eyes. So thank you guys so much.
Thanks y'all. Have a good evening.